Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha Balata from Roots Community Health Center, reporting for the week of March 13th, 2023. As health professionals rooted in Oakland, serving some of the people most vulnerable to getting and suffering from COVID-19, we're here to cut through the noise to give you information you can use to make choices that will keep you, your loved ones, and your community as safe as possible. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. This past Friday was the last day of the Johns Hopkins COVID dashboard. You can see this discontinued notice in the yellow band here that says that after 3 years of around-the-clock tracking of COVID-19 data from around the world, Johns Hopkins has discontinued the Coronavirus Resource Center's operations. And this is the data repository that many other news outlets were using to report worldwide COVID data, including the New York Times tracker. So definitely a lot of gratitude to Johns Hopkins for keeping it up while it lasted, but definitely sad to see it go. And we know that part of the reason why it went is something we've been talking about here for a while, is that case data is becoming less and less reliable. And so many of you have asked, well, then how will we know what is going on with the pandemic? We're losing trackers. The case data is no longer reliable. And I think we are at a point of the pandemic where many of the things that were built are now getting taken apart. And this does feel very unfortunate. But I'm also hopeful that there are other types of data and other types of infrastructure that have been strengthened or built that we will be able to lean on. So right now it's a bit of a process of things kind of shifting around, and we're trying to figure out what we can grab onto. So I'll talk through a little bit of that today. There are a few things that will be important for us to keep an eye on, where I do think we've built up capacity, not only here in the United States, but in other parts of the world as well. And the first one is our ability to do sequencing and track variants. The United States seemed to get kind of a sluggish start on sequencing compared to some of our other counterparts like the UK, who really has been, I think, a leader in this. But we also know that South Africa and India and many other countries around the world have continued to build upon their capacity to do sequencing. And that's actually how we were alerted to Delta and to Omicron, is because of other countries having built up their ability. And there is, in fact, a global repository where scientists from all over the world can submit their data into this GISAID database. I reported from that database many times throughout this pandemic. And of course, this is really important because we'd like to know if there are any emerging variants, especially ones that have worrisome mutations, things we might need to be concerned about. And we certainly hope that it gives us clues or maybe even a head start, depending on where it's identified, about what we might encounter next. Here in the United States, currently XBB.1.5 is still close to 90% of all sequenced specimens. Although this is the first week in quite some time that XBB.1.5 had a slight downtick, very slight, and 2 other variants are reported to have a very slight uptick, and those are 2 other Omicron subvariants, both in the XBB family. So remember, every time a variant goes over 1% of projected sequence specimens, that's when we'll see it pop up on this variant proportion tracker from the CDC. So far, we don't know of any reason to particularly be concerned about these other Omicron subvariants, but this is just something we'll continue to watch. XBB.1.5 is almost 100% of the specimens in the Northeast area where it started, and it has kind of moved out west, but even in the Northwest, where it's kind of lagged the furthest behind, it's also over 75% in that region. We know that XBB.1.5 is highly contagious, and that's why we continue to hear about outbreaks and birthday parties and super spreader events and so on with a number of cases. And this very high contagiousness is likely at least part of the reason why it's taking over so thoroughly. And so far, nothing is out competing it. And if something comes along that outcompetes it, it means that it has some kind of advantage, and we don't need any more strains with any more advantages. So even though we're not crazy about XBB.1.5, it's the one we know, which might be better than the one we don't. But it is something that we'll want to keep watching for. So we've lost sort of some of our global tracking. Our case data isn't great, but we are going to continue to keep an eye on variants. And I think this is a really important part of our overall equation. The other important data point that we'll keep on looking at, and that is quite reliable, is deaths. Now, unfortunately, the data tracker with the daily deaths that I usually show from Our World in Data has not been updated since I reported last week. So I'm not sure what's going on there. But according to the CDC weekly death trend tracker, the week ending March 8th, there were 1,862 deaths. So that's a slight improvement since we've been really over 2,000 deaths per week for a while now. But so far in 2023, 30,775 people in the United States have lost their lives to SARS-CoV-2. And for almost a year now, we have been losing over 2,000 people a week to SARS-CoV-2. So this is still a huge death toll, somewhere between 120,000 to 150,000 people per year if we stay at this level. And I sadly am not seeing any signs of this number improving right now. There are reasons to be concerned that it could actually get worse, and I'll talk about that in just a bit. The other metric that will continue to be reported upon with some reliability is hospitalizations. And we know that hospitalizations can include people who were admitted for COVID or those who caught it in the hospital. I think we can all agree that if you're hospitalized, having COVID is not a good thing, whether it brought you there or whether it came later, and that it could even turn deadly. Hospitalizations are going to continue to be monitored and tracked in the United States because one of the main things we monitor for is our delivery system and our hospital capacity. And we saw what it looks like to have our hospital capacity overwhelmed, horrific. And so that is something that going into the future, I think we can expect will be better tracked. So this is an area that I would venture to say we are where we're more prepared for the next pandemic. Of course, we want to know if our hospital systems are being overwhelmed, but one of the purposes for looking at hospitalization data is so that we can see if we're experiencing surge levels of COVID. And as we know, and as we've seen throughout the pandemic, hospitalizations do lag behind increases in cases. So this isn't a great indicator to tell us what's going on in our own area or what's coming next. It's kind of a little late. But many times throughout the pandemic, we have seen, for instance, UK would have a surge, then the East Coast, then it would kind of make its way over to the West Coast. So we're not really sure if this trend is going to continue. But as we get more time and more experience under our belt, it is possible that it may be that we can look to other geographic areas to try to predict what's going to happen in ours. We do that with the flu. We see what's going on in one area of the world, and then we can kind of predict with that pattern. So it is possible that hospitalization data is still going to be important to look at, and it should remain a reliable metric. Here in Alameda County, we have fewer people in the hospital with COVID compared to last week. We have 99 now. We had 113 last week, but we do see a pretty significant bump in those in the ICU. It's now 21 compared to 11 last week. So it is certainly no small thing to be in the ICU with COVID. And this is a concern that we're going to keep a close eye on as we move ahead. And I'll go over a little bit of why in just a moment. But first, I'll touch on the next metric I think will be important to watch, and that is wastewater. And you know, if you've been watching me, that I think that advancements in wastewater analysis could serve us well now and in the future, especially if we can get more kind of information sharing, kind of better context for how the wastewater analysis really applies to our individual situations. One of the challenges is that each wastewater plant seems to use a little different methodology to collect, to analyze the wastewater, and each one may be analyzing different or even sometimes overlapping sewer sheds, seems. There are also different methods to try to standardize or normalize the samples, to correct for things like changes in rainfall and so on. But each plant seems to do things a little differently and may even measure different parts of the SARS genome, which may have some implications, especially when we have different variants that may have different patterns in their genome. So when I look at all the three of the different wastewater readings that I tend to check for this area, this time I'm noticing that they all seem to show a decrease in concentration of SARS-CoV-2. So this is not my area of expertise to know all of the nuanced differences of these different graphs here. But when I see three graphs for the same area and they all seem to be headed in the same direction, this would seem like a good thing. And it also seems to be an improvement over what I've noticed in months past where things were more all over the place. So things could certainly get all over the place again later, but for right now, it's reassuring to see wastewater concentrations in our area trending down, and even when we're looking at slightly different data sources. And there are a number of wastewater plants reporting into the CDC across the country. I've put a link to the US map in the post, and you can drill down on your geographic area, and you can even see other viruses besides SARS-CoV-2 if that's of interest. Wastewater can even be used to monitor for things like fentanyl and other substances. So we'll see how this technology and this infrastructure can keep us better informed as we go forward. And hopefully we'll have some predictability. When we see this on the wastewater, we can expect that in terms of cases. I think that is kind of still being worked out, but promising. Case rates in Alameda County are fairly steady, but testing rates do continue to decrease. So really all throughout the pandemic, there have been limitations to using case data, but we've been able to tell when we're going up and when things are coming back down. So this will probably be only useful as we move forward to the extent that we're seeing trends, notable trends like big increases or dips. Now, you've probably heard some of the talk about whether the COVID booster should be an annual booster in the fall, kind of like we do for the flu vaccine. And we've definitely been getting questions, especially from our folks in the higher risk groups, about, isn't it time for me to get another booster since my last one was in September? And so they're now about 6 months out from that Omicron booster or the bivalent booster. I did review in some detail in the February 14th briefing, which I've linked in the post, a large meta-analysis that went over vaccine effectiveness. And it looked at primary series and boosters, but it did specifically also look at the Omicron booster. And I did a deep dive into all of that in that briefing. So if you're interested, check it out. It was a meta-analysis, so it does have some limitations, but it looked at quite a number of studies, and it's the best, kind of most comprehensive source of data seeking to answer this question about kind of the duration of protection against poor outcomes. It's the best one that I've seen so far. And basically what it showed with regard to the Omicron booster in particular is that initially it's quite effective against hospitalization, about 89% effective. So that's pretty phenomenal. So Omicron booster, about 89% effective against hospitalization after it's given. But then by somewhere around that 4-month mark or so, the effectiveness against hospitalization drops. It drops to about 71%. So again, this is an average over multiple different studies, but 89% effective down to about 71% effective around the 4-month mark. And presumably it continues to go down from there. So there weren't enough studies available in the meta-analysis to report on the booster vaccine effectiveness against death. Part of the problem is there hasn't been really enough time that's gone by to have enough data for this. And the other part of the problem is not enough people are getting boosted. In fact, as you can see here, only 16% of the eligible population has received the bivalent booster. So we're not doing great there. We're doing better with the over 65 population at 41%, but this also is not great. So these studies in the meta-analysis looked at people who did get boosted and found that protection against hospitalization is good for the first few months. Probably around the 4 to 6 month mark, we see a reduction in protection against hospitalization, and it would follow, that would be a reduction in protection against death as well. So if this is the case, then why would we be urging towards an annual booster? And I think this is a very valid question, especially for those in the higher risk categories who are already at a higher risk of a poor outcome. And if I had to guess, this is probably the reason why, even though we've definitely heard the chatter about this annual booster, we actually have not seen a definitive recommendation come out yet. So it is possible that given all this, there will be some flexibility or maybe some discretion for those people who might be in the higher risk groups. Maybe it will be more frequent booster for them. But I think the other question that's been coming up around this is, why would it be in the fall? So even if we decided a year is fine, why is it in the fall? Is SARS-CoV-2 a seasonal virus? And this is a question I've been getting, and it's a great question, especially if we're looking at this fall booster, because we do that for the flu for a reason. We do that with the flu because we know that flu season is pretty predictably in the winter months. And those are the patterns that we've seen. And so is this going to work for COVID is the question. The pattern that we've seen so far with COVID do include a winter wave that's typically been larger than the summer wave. But I'm certainly not comfortable calling COVID seasonal. And this is partly because first of all, we've had about 3 waves a year since the pandemic started. So even though the winter waves in general have been larger, COVID has happened many different times during the year, and it's been pretty unpredictable in general this entire time. You can take a look at cases in your region to see when you had each wave, and we do know that it's just a little different depending on where you are in the country or in the world. So I'll share this example from here in Alameda County. The top graph shows confirmed daily cases, and the bottom graph shows confirmed daily deaths. So if we focus now on the top graph, we know that we had a spring 2020 wave. But it was way undercounted and underreported because, as we can all remember, there was not much testing availability at that time. The far left on the lower graph, where you can see we had deaths, even though you don't really see the cases reflected there because it was just getting started. And even in July of 2020, cases were probably still undercounted because all the testing sites were just overrun. The labs were backed up. It was just, we still were kind of building capacity overall. And basically the capacity was nowhere near the demand. So again, undercounting of cases there, but we definitely had a wave in July with, again, corresponding deaths. Our winter 2021 wave happened in early January. And then the following summer, our wave was in mid-August, so late summer, about a month later than what we had seen the previous year. And then our Omicron wave in January of 2022 happened a few weeks later than our 2021 winter wave. And the following summer, which is this past summer, 2022, the peak was in early June. So notice that we've had summer waves in June and July and August. So this doesn't feel like a very predictable or seasonal pattern at all, actually. And then this winter, our wave was actually kind of in early December. And there seems to be maybe a little bump that we're just coming down from now. But again, we're back in a situation where the case counts are very unreliable and very much undercounting, and they have been for some time now. But basically, in every way, we know that there are corresponding deaths, and those typically lag a few weeks behind after the cases. So bottom line, we've had winter waves anywhere from early December to mid-January. We've had summer waves in June, July, and August. So basically, just here in Alameda County, we've had waves in 6 different months already. There's only 12 months in a year. So this is not particularly feeling seasonal or predictable so far, which is a main reason actually why we are still in a pandemic, because we have not settled into any kind of predictable pattern. So we do know that for the most part, the winter waves have been the largest, although we're going to see what this summer wave looks like and if it gets bigger than this past winter. So we really just don't know. We just don't know. But so far, the winter waves in general have been the largest. So from that standpoint, it could make sense to get a fall booster so that the majority of your protection is over the winter wave. But this seems to leave out a lot of the year, and it actually leaves you with the least protection in the summer, which is when we've had our next biggest waves. And they've been significant waves. So if you're someone who got the booster in September or October and you're in a high risk category, that protection could be kind of wearing off by now, but it would be at its lowest point in the summer, which doesn't necessarily seem ideal if we're going to continue to have kind of waves sometime in the summer. And this is, before a fall booster. So it might be okay that the protection is kind of wearing off right now, because cases seem to be a little lower, although we do still have a fair bit of COVID circulating around in our environment. But let's say we have another wave in June or July or August. It does bring concern that some of the people who are most vulnerable to a poor outcome, who are also probably the first people to get the Omicron booster, so they got it the earliest, they might not have great protection at that point as the summertime wave kicks in. So at this particular moment, I don't think there's anything we need to do about it other than keep our ears open for the updated guidance and also try to keep an eye on when we may be hitting our next wave, with all the remaining metrics I've been talking about. And just keeping in mind the unpredictability that we've encountered with SARS-CoV-2 up until now. And once you start to get about 6 months out from your bivalent booster, then you should consider yourself less protected and act accordingly. And if you're a high-risk person and you've not gotten your bivalent booster, what are you waiting for? Now would be a great time to do it. It should give you good protection throughout the summertime and hopefully cover you for those summertime waves. And there's really not a reason to wait, because if you haven't gotten the bivalent booster yet, if you haven't had any COVID vaccine for over 6 months, then we do worry that you don't have the protection of the bivalent booster and that the protection from your primary series or even your previous booster has diminished. And I'm not talking about antibody protection here. Remember, I'm talking about what we seem to be able to understand from a number of studies that are actually looking at protection against severe disease, hospitalization, and death. So for now, I personally cannot get quite comfortable with the notion of an annual booster, and I will be waiting with interest to see what the formal recommendations will be. Brief word on norovirus. It doesn't look like it's slowing down just yet. It's still quite prevalent in our wastewater. All you got to do here is pretty much wash your hands, wash your fruits and vegetables and whatnot. I went into some greater detail about norovirus a couple weeks ago if you'd like to check out that prior briefing. So it is important to remember that we still do remain in a pandemic with SARS-CoV-2. I reviewed a little bit last week about how we know we're not endemic in the endemic phase, and it remains to be seen if and when we will be. But according to the World Health Organization, we remain in a pandemic, and COVID-19 continues to constitute a public health emergency of international concern. This is the highest alert that they can issue to the world, and we're still under that alert. We should not consider the United States administrative decision to end the public health emergency as anything more than that. It has nothing to do with the state of the pandemic itself. We know that the end of the public health emergency has to do with the need to remove several provisions and allowances and, frankly, funding to respond to the crisis. And much of the justification to kind of move on from the public health emergency declaration does seem to have to do with the availability of treatment in the case that people get sick with COVID. But that does not change the fact that we have quite a bit of COVID circulating around our environment. And despite the fact that treatment is available, quite a number of people are catching COVID. Some of those people are being hospitalized. Some of those people are dying. About 300 to 400 people a day are dying still. And some percentage of folks are suffering with post-COVID events and long COVID effects which are very worrisome. And they're the things that we seem to know the least about at this point. And until we know more, it would certainly be prudent to avoid infection and reinfection and avoid spreading it to others. So please don't show up to work or school or the gathering or the party feeling sick and exposing others. Stay home and rest, please. But if you do insist on going out, wearing a well-fitted N95 mask is considered source control, and it will reduce the risk that you sicken or even kill another person. Gather outside, improve indoor air quality, wear a high quality filtration mask like an N95 or a KN95 or a KF94. Use rapid tests for pre-event testing. If you get exposed or have symptoms, repeat your rapid test every day or two while continuing to wear a filtration mask. And you can also consider going ahead and getting the more definitive PCR test, especially if you're someone who would be treated if you're positive. Also, pay attention to your benefits. If you are a Medicaid beneficiary, please update your information so that your state Medicaid office will know how to reach you. If you're in California, use the link in the post to update your contact information. And if you do not have a primary care provider, please get one. Know how to reach them before you need them. Make a treatment plan for COVID. Know now, before you catch it, if you're someone who should take Paxlovid. And make sure that you are up to date on your boosters. And if you didn't want the mRNA vaccine, remember, you can get the Novavax vaccine, a protein subunit vaccine. And as always, remember to eat a balanced diet. Consider a multivitamin supplement to fill any gaps in your nutrition. Consider getting your vitamin D levels checked when you go to your doctor to get checked for all the other things like cholesterol, diabetes, and your blood pressure. Get some regular exercise. Unless you're sick, then we want you to rest. It may even reduce your risk of long COVID if you're sick with COVID. Manage your stress levels and get a good night's sleep. This concludes today's People's Health Briefing. Thank you so much for joining us, and we'll see you again next Tuesday at 10 a.m.